Bismillahirrahmanirrahim. Today I'll be discussing the role of endoscopic ultrasound in the staging of luminal GI malignancies. As you're aware, endoscopic ultrasound scan is a modality that combines the powers of endoscopy and ultrasound scan and helps us achieve various diagnoses. The first commercially available EUS machine was in 1998, and the most modern ones contain an ultrasound scan machine, endoscope processor, and an EUS scope and a monitor. There are two types of echo endoscopes. So one is the radial one, in which you get 360-degree assessments. So the images are quite similar to a CT scan, and it is best suited for staging. Whereas the linear scope has a narrow view, but it has the ability to take biopsies. So this is my summary slide. The role of EUS in staging can be defined in various areas. So in the esophagus, there appears to be a definite role in differentiating T1, T2 disease from more advanced disease to assess which patients require neoadjuvant therapy. It has also got a role in differentiating T1A and T1B disease to assess which patients can be managed with ESD, and also to assess patients who have lymph nodes to see if they are malignant or not, which can determine their operability. In gastric cancers, there is a probable role in early gastric cancers. However, there is some controversy and there appears to be an east and west divide. Whereas the role of EUS in rectal tumors is quite limited with the advent of MRI scan of the pelvis, which produces very good staging results. So discussing each one of them separately, as you're aware, the cancer's staging is determined by the TNM classification, whereas the T suggests the depth of the tumor invasion. A graphical representation of this is as follows, in which T1 disease remains confined to the mucosa, T2 disease reaches but does not involve the muscularis mucosa, T3 disease goes through the muscularis mucosa, whereas T4 disease can involve the adjacent structures. These layers can be assessed in the EUS scope as 5 layers. So the first light layer is the superficial mucosa, then the dark layer is the deep mucosa. Again, the light layer is the submucosa, whereas the fourth important layer, which is dark, is the muscularis mucosa, which coincides with this dark layer here, and the fifth light layer is the serosa. So in this image, the cancer invades the submucosa, but not the muscularis propria, which is T1 disease. In this next image, the invasion is into, but not through the muscularis propria, which suggests T2 disease. In this third image, the invasion is through the muscularis propria at 8 o'clock position, where the white arrow is, which suggests T3 disease. And in this last image, there is invasion of the aorta, which suggests T4 disease. So the degree of involvement of the hypoechoic or the muscularis propria layer, fourth layer, differentiates between T1, T2, and T3 tumors. And this is important because T3, T4 tumors often have nodal involvement and may require neoadjuvant therapy as compared to T1 and T2 tumors that could be managed with resection alone. In a systemic review of 27 studies, EUS was found to be highly effective in differentiating T1 and T2 tumors from T3 and T4 cancers. The specificity for EUS is more than 90%. The sensitivity for early T1, T2 tumors is more than 80%, but as the tumor progresses, the sensitivity increases to over 90%. The second role of endoscopic ultrasound scan in staging of esophageal cancers is to differentiate between T1A and T1B disease. As you're aware, the T1 tumors can be split into subcategories depending on the depth of invasion. T1A disease may be managed by endoscopic resection alone, whereas T1B disease requires surgical therapy. This is a graphical representation, and this is the area of interest. So as you can see here, T1 disease is located and does not involve the muscularis mucosa, whereas in T1 disease, the muscularis mucosa is infiltrated. The standard endoscopic ultrasound scan that we have has got a frequency of 7.5 to 12 megahertz, and it struggles to distinguish between the various T1 subclasses. And for that, we've got a device called the mini probe. This is a smaller device with a small outer diameter that can be introduced through a normal scope. The advantage of this is that it can reach various anatomical locations where the EUS radial scope, for example, cannot reach. But more importantly, it has a higher frequency up to 20 megahertz, and this gives a high resolution image with relatively low penetration depth. So with this high frequency mini probes, the esophageal layers can be now seen as 9 layers, with the first and second being the superficial mucosa, the third being the lamina propria, fourth being the muscularis mucosa, 6th, 7th, and 8th being the muscularis propria, and the 9th being the adventitia. And with this, we can differentiate the 4th muscularis mucosa layer, which helps us differentiate between T1A and T1B disease. The reported accuracy of the mini probe is quite high, as up to 80%. However, the accuracy increases with the operator's experience, as Dr. Riyaz had mentioned, of the importance of the variability of reporting based on experience. There is a learning curve with EUS staging. There are some challenges with these mini probes. So, for example, there is limited depth of penetration, not more than 2 centimeters. Also, there's a concept of acoustic coupling in which the EUS scope has to touch the tissue without any air in between for it to produce a reasonably good image. This is a challenge with the small mini probes, but this can be overcome by fluid immersion techniques in which the body is filled with water and then EUS is performed. Or the second technique is the balloon technique, in which a small balloon is attached filled with water, which assists in coupling. But the accuracy of EUS for a mini probe for T-staging of superficial tumors is pretty good, with an ROC under the curve of 0.93 to 0.96. There is, however, diminishing importance of the EUS for T-staging of superficial tumors over the years. Especially in our setting, one of the main reasons is a small number of patients, as we lack a surveillance program. Also, the EUS mini probe availability is not everywhere. And there's a cost and expertise also that is involved. There is some inter-observer variability, so there's a learning curve. And also the pathological results of the endoscopic resection appear to be more accurate for lymphovascular invasion as compared to EUS staging. What about the end staging? So EUS is very good at identifying malignant lymph nodes, and it can use the following features to identify the malignant lymph nodes with good accuracy. So if the lymph nodes are more than 10 millimeter in size, if they are discrete, round in shape, if they've got a sharp border, or if there's an absence of the central intranodular vessel, then you can say with reasonable confidence that this is a malignant lymph node. If the following three are also added, then the sensitivity and specificity of this increases further. So the lymph node, if it's present near the lesion, or if there are large number of lymph nodes, or T3, T4 staging is present, then the accuracy is quite high. Now we have another trick up our sleeves, which is the elastography, which can help us differentiate the stiffness of the tissue. So if it's a hard tissue, it appears to be blue in color, and if it's a soft tissue, it is red or green in color. And with this, we can identify whether a lymph node is malignant, such as in this case, it's blue in color, which is hard, whereas here it's green in color, which suggests an inflammatory lymph node. So the overall accuracy of EUS for initial end staging of esophageal cancer is pretty reasonable. For metastases or M staging, cross-sectional image is preferred with CT scan. PET scan should be offered to every patient who has had an esophageal tumor, as 20% may be upstaged based on this. Laparoscopy can also be offered in patients who have had T3, T4 adenocarcinomas arising at the GOJ or cardia. But once the malignancy metastases has been confirmed, then EUS is not indicated for further staging in this group of patients. Moving on to gastric cancer staging. So again, the TNM classification is used to assess the extent of gastric wall involvement, but EUS is thought to be a reliable non-surgical method available for evaluating the depth of invasion of gastric cancers. And in a study with suspected early gastric cancers, EUS staging was pretty accurate, especially if a mini probe was used. So the early gastric cancers are defined as adenocarcinomas limited to the gastric mucosa or submucosa, and their significance is that they have a much better prognosis with approximately 90% 5-year survival rate. In Japan, the proportion of the early gastric cancer has risen from 15 to 57% with the introduction of the screening programs. However, standard endoscopy is also pretty good in identifying patients that have got advanced diseases. So patients who have a tumor of more than 2 centimeters, or which has irregular surface or ulcerations, which has marked marginal elevations, or has clubbing, abrupt cutoff, or fusion of conversion folds, we can say with a 78% accuracy that these patients have advanced diseases and may not benefit from ESDs. Also, the endoscopic submucosal dissection is considered both as a staging procedure and a treatment for early gastric cancers. And the additional advantage is that ESD does not preclude subsequent gastrectomy if the resection is incomplete or if there's unfavorable histological findings. And because of this, there's an east and west divide. So whereas in the West, we tend to do EUS for patients with early gastric cancers, and only if it's favorable do we move on to ESDs, whereas in the East, they tend to move on first to the ESDs, and if the sample suggests unfavorable outcome, then gastrectomy is offered. With regards to the nodal involvement, there are several regional lymph nodes in the stomach that can be involved. And because of that, the end stage accuracy is not great with endoscopic ultrasound scan. Also, some parts of the stomach are not very well visualized with EUS, and therefore the influence of EUS on patient management with regards to end staging in gastric cancers remains controversial. As before, if metastases are identified in any cross-sectional images, then EUS is not indicated. Moving on to rectal cancers, again with the T-stage involvement, this is a graphical representation from T1 to T4, which suggests the depth of the tumor invasion. However, when EUS, that is endoscopic rectal ultrasound scan, is compared with MRI scan, there doesn't seem to be any major difference in the T staging. Also, with regards to nodal involvement, when compared to MRI scan, there is no statistical significant difference between MRI scan and endoscopic rectal ultrasound scan. And therefore, all of the algorithms for staging workup for rectal cancer prefer MRI scan initially for staging. EUS may have a role in patients who have got a contraindication to MRI scan or have suspected but unconfirmed internal iliac lymph nodes. Again, if metastases are identified, then EUS is not indicated for further staging. There seems to be an interesting role of ERUS in surveillance of patients post-resection, but the optimal selection criteria is still uncertain. Certain groups suggest high risk patients with high risk of recurrence, whereas other groups suggest patients who have had transanal excisions should be surveyed using ERUS. However, once the recurrence has been identified, then further staging with EUS is not great because of post-inflammatory and post-radiation changes. Fiducial placement is also possible. So fiducia are small little metal bits that can be placed via EUS into the tumor. The radiation oncologist then can identify these and which can guide them to perform more accurate radiotherapy. So in summary, there is a definite role of EUS in the staging of esophageal cancers and can help identify patients that can be selected for neoadjuvant chemotherapy, for ESD, and also for operations. Whereas in gastric, there is a probable role in early gastric cancers. However, there's an east and west divide. In rectal tumors, the role appears to be very minimal and is only limited to patients who have got contraindication to MRI scan. Thank you very much.